Well, welcome everyone. Today, we are honored to have with us Dr. Dietrich Klinghardt, who I've known for many years, actually one of my earliest mentors in helping me understand some of the basic foundations of natural health and how one can uh, apply it to facilitate and accelerate healing. And I have to first start off this interview with a warning, though, and that if you become a fan of Dr. Klinghardt, the key thing is that to know is that things will change. So he's always on the leading edge, and things are always different. So I'm always amazed when I come back to him how much more he's learned. When you think you learned it all, you find out that there's an order of magnitude more to learn. So that's what he's going to enlighten us on today. And a very important topic, which is Lyme disease. And some experts feel that almost everyone has been exposed to Lyme disease and may have it in one way, shape, or form or another. But clearly there are those who have it who are severely disabled and crippled. And Dr. Klinghardt has actually suffered with this himself. So as a result of this, he has a personal passion and really has been on this journey that he's going to share with us and really tell us how he's evolved in treatment strategies and protocols and what he's learned from his many decades of clinical experience that is found to be effective. So welcome back, Dr. Klinghardt.
Thank you, Joe. It's good seeing you again.
Yes, indeed. Likewise. So, well, we're here today to talk about the Lyme disease. So why don't you start, because you're just a phenomenal lecturer. And, one of the comments I neglected to mention is that when you do attend one of your lectures, I mean, it seems like you can just go, I don't know anyone else who's more skilled at going on and on for hours and hours without any notes or PowerPoints. I mean, you're just a wealth of knowledge. It's just shocking. So let's start wherever you feel is appropriate, and then I'll dialogue and interject with some questions as we go along.
The issue with Lyme disease that it's really the only thing that's new with Lyme disease is that many of us have realized that pretty much all chronic illnesses are in one way or another way the outcome of chronic infections, or at least contributed to by chronic infections. Even 15 years ago, most of us thought that chronic illness is the outcome of toxicity, of environmental toxicity and everything related to that. But we got a little wiser and realized that the issues go far deeper. And what has been astounding to us, when we look at illnesses that are well established in the conventional medical field, like Parkinson or multiple sclerosis or chronic fatigue, they're all turning out to be primarily chronic infections with this particular expression of it. And right at the center of that is really the ongoing discovery of Lyme disease. And when I say Lyme disease, I like to use the new definition of the new Lyme disease. That means it's an illness transferred by insects. And please hear me here, but we're not calling it anymore tick-borne disease, because we know that mosquitoes can carry Lyme disease and many other serious infections. We know that spiders, fleas, mites can carry these illnesses. And so to limit it to tick-borne diseases, as it was until recently, has been too narrow a focus. And I like to take a big look at this whole thing. In modern genetics, when we break down our genome, we find entire long sequences in there that come out of the insect kingdom, that come out of the bacterial kingdom, out of the viral kingdom, that actually have become part of the human genome. What that basically means that we're in the process of discovering a new theory of evolution, that these chronic infections were always an attempt of evolution to mingle with our genes, to expand them, to change them, and once in a while something good comes off it. And I may have mentioned that already in my last interview with you, that impressive examples of that are some of the carriers of spirochetal illness in the past, starting with Nietzsche. Nietzsche was infected with syphilis, and in the course of the illness had one of the most creative philosophical outbursts ever happened to humanity. I could also mention Mozart. Mozart was treated with high doses of mercury in the late stage of his life because he had contracted syphilis and died of mercury poisoning. But during the course of his illness and during the course of the treatment of the illness, he created some of the most beautiful music ever. Beethoven lost his hearing from the mercury treatment for syphilis. These are just a few examples of people that had a well-known spirochetal illness, and this illness was clearly contributing to their enormous creativity and maybe even clairvoyance and breaching their perception into the other worlds, into the invisible world around us. And so I'm taking today a very, very different approach to Lyme disease. I look at it as there is nature mingling with our genes, trying to incorporate their genome into our genome, and with the possible outcome that something good may happen occasionally. Most of the time it goes wrong, but sometimes it goes well. So this is like a point I want to make up front, that I take this more evolutionary view of it. And then on the darker side of things, we do have some government documents that were leaked to us that shows in the 1960s and 70s and maybe into the 80s, there was some wild experimentation going on in U.S. military-linked government documents that showed that the U.S. government and other governments in the world were very well experimenting with recombining different microbes in order to create stealthy microbes that make large populations ill, so they lose their will to fight and to attack. And whether these things were ever used or so, we don't know. But we know there were experiments going on, and it is unfortunately increasingly likely that some forms of Lyme disease are actually a microbe that has some human elements in it. That means elements, it's likely that they are God-made creatures that evolved on their own, but that somebody helped along with it. I'm always puzzled when I go over to Europe how different patients with Lyme disease look there. I work half my life over there as a physician and half my life here. And the people in the US with chronic Lyme disease are far iller, have far less energy, and it just looks like there is a viral element in our Lyme disease that we see here that is not present in Europe, and that cannot be explained on pure biological grounds. So this is just some thoughts up front. We do have some anthropological evidence that spirochetes were around for a very long time, thousands of years. We know that Bartonella, one of the significant co-infections, were found in the soldiers of Napoleon who died in Russia. It was called trench fever. It was Bartonella quintana, a very nasty bug. And the Russian general, the Russians lost a lot less soldiers because the Russian general was a homeopath, and he had all his tens of thousands of soldiers taking homeopathic dilutions of their own saliva, which saved a lot of their lives. So there's we know that Lyme spirochetes were around for a long time, but something happened maybe 30 years ago, 40 years ago, where the creatures became more aggressive, more penetrating, and more illness-producing than they were before. And some of us suspect it's a man-made element. Some of us suspect that the global warming may play a role in it. I'm personally suspecting that the exposure to electromagnetic fields in the home and the microwave coming in from cell phone radiation are driving the virulence of many of the microbes that are naturally in us and makes them aggressive and illness-producing. And so, there's probably evidence for all sides of the discussion. And what I'm trying to do when I see a patient, we try to okay, we try to assume when somebody shows up in our office with a chronic illness, we're not just suspecting there may be a chronic infection in the background, but we're looking for it. We're looking intentionally we're not asking, could it be that this patient has a chronic infection? We are asking the question, okay, the patient has a chronic infection, what is it? And then we try to define it, to narrow it down, to find it, to prove it that it's there, and then find the most gentle but the most directed treatment to treat it.
Well, thank you for that introduction to Lyme. And how would you describe for those listening some of the more common symptoms, and then from the symptoms go into the process of getting a proper diagnosis? Because one of the big challenges that anyone who's really familiar with Lyme disease has been that it's notoriously difficult to I guess test with traditional blood testing.
Mm-hmm.
So maybe if you can address that. And again, some people like I forget, Lyda Matson, I think is their name, believes that everyone at least in this country in the United States has been infected with Lyme. So I mean, there's a whole range of views on this, and I'm wondering if you could share with us your views on it.
Yeah. So that was Lyda Matman, by the way.
Oh, Matman, okay.
Yeah. So in terms of the presentation of the illness, first of all, there's a great variety depending on where people contracted the illness. And then there's a great variation depending on what other infections or infestations the patient has. The contribution that me and my co-workers here in the office made in the last couple of years is that we differentiate very clearly between Lyme and its co-infections. That means that these are infections transferred at the same moment with the same insect bite as these Lyme spirochetes. And there is a group of bugs, there's 7 or 8 microbes that are common. The worst ones are Babesia microgyne and the different forms of Bartonella. There is a large variety, again, amongst those creatures. And then underneath that often is an infection with mycoplasma, where we still don't know if it's really transferred with the same bite or if the people had it all along and become symptomatic when the immune system is suppressed by the spirochetes. Then, other than the co-infections, there is what I call the opportunistic infections. The combined effect of the initial infection is an immune suppressive effect. And then the patient becomes vulnerable to all sorts of other things. And the most common things that people contract early on in the course of the illness is different forms of parasites. There's protozoa, Babesia being itself one of them, but there is Giardia, amoebas, trichomonas, malaria, different forms of infections that aren't labeled yet. There is a new one, it's called FL1953. Stephen Fry has discovered that. That's a protozoal organism that's causing severe fatigue and illness in chronically ill people. That's almost always present in a patient with Lyme disease. And then we find a lot of worms in people. And they may be microscopic and they may be macroscopic. That means they may be visible in the stool or they may not be visible. And we'll get to the treatment later, but it's important. There's the initial onslaught of microbes with the insect bite or several insect bites or in several locations, since most of us travel. And then there is opportunistic microbes that come on board after the initial event. And that colors the picture so differently in different people. And then, of course, there is the backdrop of genetics in the person coloring the picture. And then there is the nutritional background, the emotional background, the exposure to electrosmog, which all tweak the picture. So because of that, there is a large spectrum of illnesses that when we see them, we suspect that there may be a Lyme disease at the bottom of it. And let's start with the most simple presentation is the orthopedic forms of Lyme disease. They're usually a little bit more superficial. People still feel well, but they have knee pain or hip pain. Typically, it's the large joints. I've rescued many, many hips from the orthopedic surgeons, by injecting ozone into the hip joint. Ozone is 100% effective if the Lyme disease or mycoplasma or rickettsia, whatever the microbe is, lives in the joint and is confined to the joint space. Then by simply putting ozone in the joint will kill the spirochetes, and often with one, sometimes two treatments, make the joint completely pain-free. That's one form of the expression of Lyme. The next one that's a little bit more difficult is when the microbes and the associated immune reactions live in the connective tissue. Then the patients get vague, dispersed pain syndromes, which usually are sent to me under the label fibromyalgia, but usually it never turns out to be the proper fibromyalgia with the 18 or 20 typical trigger points, but there is widely spread pain in the body. And again, when we do the appropriate lab work, we find often that these people are infected. So this is a little bit about the orthopedic expression, which are the easier ones to handle. Then we have an immunological expression. That means a wide variety of immune system disorders, usually with some aspect of autoimmunity. You probably remember I did my thesis in 1976 on autoimmune diseases and how the autonomic nervous system interacts with the immune system. And we found then already that the determining factor of the outcome of an autoimmune disease was the presence of microbes that were catastrophically unresponsive to antibiotics. And so any autoimmune disease, including rheumatoid arthritis, we're suspecting there's an underlying level of Lyme disease that needs to be handled and treated appropriately before the patient has a chance to snap out of the illness. Then the third expression that is very common, especially with Babesia, is the gastroenterological presentation, where people have constant stomach problems, recurrent stomach ulcers, indigestion, constipated, they can't move their bowels, they can't absorb their food, and so forth. Sometimes, with the direct outcome of pancreatitis or hepatitis, the associated organs becoming ill. That is very frequent, but usually an outcome of the parasites that have come on board after the patient contracted the Lyme disease. And in these cases, we very aggressively treat the parasites, and I have to say very successfully. And then the most startling form of the expression of Lyme disease is a wide variety of neurological illnesses. And that is what we're specializing in here in the office. We see a lot of cases with MS, unfortunately also ALS, but then everything in between, the chronic fatigue patients, the patients with vague, undistinguishable neurological symptoms, the feeling of buzzing in the head, of buzzing on the skin, crawling under the skin, symptoms that are described in the homeopathic literature 400 years ago. Hahnemann described those same symptoms, and so we know spirochetes were around then doing the same. Insomnia may be one of the key symptoms that we see today in our Lyme patients as a neurological symptoms, and headaches of all varieties, all sorts of pain syndromes. I lump these together under the neurological expression of Lyme disease. And the key to diagnosing that the listener, please keep in mind that most commercial tests that are available in medicine to detect chronic infections are based on appropriate immune reactions that the patient has to the invading microbe. So we're looking for IgG, IgM antibodies. This is the antibody response the body mounts, the white blood cells mount to kill the microbes that are there. However, the equation changes once we know that one of the primary cells that get infected with Lyme spirochetes are the white cells themselves. And if they're infected, they lose the ability to produce antibodies. And so I call this the first Lyme paradox. that in order to diagnose Lyme disease properly with one of the accepted commercial tests, we have to first treat the Lyme disease enough for the patient to be able to mount an appropriate immune response, and then we can use the laboratory to detect it. An exception to that are the tests based on direct microscopy, where we're not depending on the immune responses for the patient. Problem with the direct microscopy is that the tests that are done commercially, for example, the FISH test for Babesia, are done on the blood. However, the concern that we have, for example, with Babesia is its presence in the central nervous system and in the joints and in the connective tissue. We are not concerned about its minimal presence in the blood. And Babesia, for example, can be easily missed in the blood because it doesn't live there. It strays there occasionally in small amounts, but it lives in the central nervous system and in the joints. And we don't have an easy test. We could do a brain biopsy, but it would be just as easy to miss it there than to miss somewhere else. So the problems with the direct microscopy is that the tissue that we usually look at is the blood, and that's the one tissue where Lyme disease tends to only stray into from time to time, maybe on the full moon, maybe when the patient goes through a trauma, but it doesn't live there, not in high amounts, and it's the same problem with the PCR testing on other testing. So this is just to introduce you to the testing conundrum. And I like to just say what we're doing here. We are very simplistic. We treat the Lyme disease for at least 6 weeks to 2 months. Then we tend to do a Western blot test. That's the test that's based on IgG and IgM.
Is your treatment initially based upon the clinical symptoms that you just described? So the high suspicion that this is Lyme disease, and then you treat empirically without any, or I think you probably do some more sophisticated energetic testing, I would say. I'm not sure if you want to review that now.
Yeah, I think I can be honest about that here, because I'm trying not to hide anything that we do. We use a form of muscle testing that I've developed. It's called autonomic response testing, that incorporates many features of regular neurological testing. This means we're testing, for example, the cranial nerves in a classical way. We test the reflexes, the ankle clonus. We test the Babinski. We test skin sensitivity to vibration and touch. And we're arriving, before we get to the actual kinesiology part, to the muscle testing part, we're arriving at the tentative diagnosis that we will then further refine with the muscle testing. I developed a system called autonomic response testing that has grown really out of the need for a physician to penetrate deeper into the system. It's not related to the applied kinesiology system. It's quite distant stretch from it, but it may look on the outside similar. But we're looking for very specific reflexes that are connected to very specific illnesses. And we arrive at a tentative diagnosis through history taking, through looking at some of the skin signs, through palpating the tissues, through testing the normal neurological reflexes, orthopedic tests, and then adding the muscle testing in as an additional tool. When we arrive at the tentative diagnosis, then we start with my approach to Lyme disease, which I'll get into later. And then 6 weeks into that, we do the blood test. And we have a very, very high level of correlation. When we do the blood test at the right time during the treatment, it usually turns out positive. I have to say that we use very strictly IGeneX lab in Palo Alto. I don't have a financial investment in it or relationship, but it's the gold standard in our field. They use 2 different antigens. The commercial labs and hospitals and so forth, they use one antigen and are notorious in underdiagnosing Lyme disease. And so we recommend to rather not test it than get a false negative test, which will sometimes lead the patient for 20 years on the wrong track. With the other co-infections, the detection rate drops way down. Babesia is much harder to diagnose. We do the FISH test at IGeneX lab. It's a direct microscopy test, which has more false negatives than the Western blot has for Borrelia. And we use various tests for Bartonella, but the leading test for Bartonella that we use is Fry Labs in Arizona, FRY, Stephen Fry, who does a wonderful direct microscopy test and often comes back positive with the diagnosis of hemobartonella. Hemo means simply blood, Bartonella in the blood. And remember, he's testing the blood where the Bartonella typically does not live. It lives in the nervous system. And so if he finds it in the blood in small amounts, it generally is an indicator that there's a high amount in other tissues in the body. The principle that we really should do tissue biopsies has not been practical. And so these are the three tests that we do for the bugs themselves. And then we do one indirect test that hasn't changed, that Raphael Stricker from San Francisco has given us. It's the CD57 test. The CD57 is one subgroup of natural killer cells that are particularly damaged by the Lyme spirochetes. And if the numbers drop down to a certain level, it is an indirect indicator that the patient most likely has Lyme disease. There is simply no other infections known other than Borrelia burgdorferi that suppress CD57. And so the general guideline is the value should be over 100. If it's under 100, the patient has an infection with Borrelia. If it's under 60, the patient has an infection with Borrelia plus Mycoplasma, plus most likely some other co-infections. And we very commonly start at levels of 7 or 9, when we start with the patient, and gradually over the year and a half or so that we typically treat people, the levels go up back over 100, and then we're all happy. And usually stop treatment, but keep monitoring the CD57 maybe every 6 months or so. If it drops back down again, we know it's time to treat again.
Thank you for that explanation of the sort of an update of the current status of the different tests that are available for Lyme. One of the other ones that you didn't mention, I learned about recently from another clinician, Dr. Cowden, who treats Lyme somewhat similarly to you, and I'm wondering if you could comment on it because some people might have questioned on it, and that's the Spirostat lab.
Yeah. Mm-hmm.
So if you can give your impression on that and how that might fit into the scheme of things.
I know that my friends in the Lyme community are increasingly using the Spirostat test, and it tends to be offering less false negatives than the other tests. I have not used the Spirostat test because I'm waiting until there is enough common agreement on the validity of it. I know it's a good test. I talked to the lab. I trust them. I think it's a big breakthrough in our field. But I'm always, my position is I'm trying to have our patients get reimbursed by the insurance companies and put their treatment on a stable ground, so where the insurance adjusters that decide whether the patient is going to be paid for or not is usually a secretary that didn't finish public school in terms of her educational level, who's making all the decisions for the patient. And so for this reason, I've stayed so far with the IGeneX lab because we had a very, very good success rate in, if it's positive in IGeneX lab, that the insurance then was willing to pay for the procedure. I know Spirostat is very close to gaining the same status, but from what I hear, it's not quite there yet. But it may be the better test, but really that's all I know at this point. So,
okay.
All
right, well, thanks for that. I wondered if you could also address Lyda Matman's premise or hypothesis that most everyone's infected with Lyme, and what's your experience been? Because she's really more of an academician, and really PhD, not really treating patients as much as you are in the trenches treating people with the disease.
I have an interesting history with Lyda Matman. I was introduced to her in 1990 through a dentist who was also an osteopath like yourself. Chris Husser. And Chris Husser had worked with a biologist, Phil Hoekstra, who was a direct student of Lyda Mattman. And I was introduced to Lyme disease actually through the lineage of Lyda Mattman's teaching. Lyda Mattman was the discoverer of the cell wall deficient forms. Basically, when microbes, before Lyda Mattman, we knew microbes to swim around in the blood and do things there, or even in the connective tissue. But we only thought of viruses actually penetrating in the cell, infecting the cells, until chlamydia came around and gonorrhea, which are clearly strictly intracellular microbes. So people were wondering, how are these bugs doing it, that they're penetrating the cell wall, such large creatures? And Lyda Mattman found that bacteria to infiltrate, to enter a cell, have to shed this, they have to give up the cell wall in order to be living in the intracellular environment. And that was her great discovery. And of course, we know now today that there is an intracellular form of Lyme disease, and there's an extracellular form. The outside of the cell, the spirochete looks like a corkscrew. On the inside of the cell, it may look just like a blob. And so Lyda, I think she's got a Nobel Prize, or at least was nominated for one. So she was not a small light. She's internationally, everybody in Germany, Switzerland or so. When I mentioned Lyda Mattman, the people want to bow to me. And I have to say, no, I met Lyda a few times, but she was not my primary teacher, so I can't really brag about it. But Lyda Mattman has internationally high level of trust. And in the late phase of her life, she felt, based on the tests, the direct microscopy tests that she used with a particular stain that she developed to make Lyme spirochetes visible in the blood, she felt that the penetration in the US population is nearing 100%. That means everybody has it, but not everybody is sick with it. And I'm not subscribing to one theory or another, but certainly amongst the patients that come through my office, sit in the waiting room and come into my room, most of them turn out sooner or later to be positive testing for Borrelia burgdorferi, many of them for Babesia, many of them for Bartonella, and Mycoplasma and everything else that comes with it. So I do believe that post-mortem, Lyda Mattman is going to be redeemed and going to be found correct in her observation. However, I want to put that in context, that I am personally suspecting that the spirochetes were always with us from the beginning of humanity. We're a couple of 100,000 years old now since we climbed from the trees. And I believe this history goes way, way back. I know that in the Black Forest area in Germany, where I come from, the women, especially the women, when they're like 40 years old, they get these big, kind of huge knees from athletic activity in the knees. And that was already known in the 1930s. That's the outcome of a Borrelia species that lives in the Black Forest. It's called Borrelia afzelii. That didn't do much other harm other than just affecting the knee joints, and they were moving more slowly. But these women reach a normal, healthy age of the 90s or early 100s before they die, but with big fat knees and a certain amount of stiffness in the knees. And it's still like that today. That was known in 1930 that they had spirochetes in their knee. And so I'm just suspecting that these creatures were along with us for a very long time. And what really has changed is the influence of the external factors, and that is the toxicity in us, in the air, in the food, but amalgam fillings, root canals, the food residues, all the things you talk about in your website, the vaccines. That's one big aspect, and one that we know for sure because there is research on it, shows that the electrosmog, just the ambient fields in the house, the 60 hertz field, drives the growth and the virulence of the microbes that live naturally in us. And we know that the amount of microwave we're exposed to from the cell phone radiation is near doubling now every 2 years. The amount that we're exposed to is doubling, and has reached clearly catastrophic amounts, where One of my primary treatments for Lyme disease, and I know we'll get into treatment, is to put people in protective clothing that shields them from incoming microwave. We shield the bedside. We turn off the wireless internet at home. We put shielding paint on the houses. And that has been a more successful strategy to treating Lyme disease and to get people neurologically well than any of the antibiotics or any of the antimicrobial compounds. It just has been more successful as a single strategy. And so I know it is wrong for us to overly emphasize on the microbes. We need to know what's driving the microbes nuts in us. They were historically living with us happily, symbiotically. They may have always caused mild damage, we don't know, or a premature aging, we don't know for sure. But this virulence that is appearing now is a new phenomenon, and it could be explained only with two things. One, a mutation of the spirochetes, or one of the yet invisible co-infections or opportunistic infections. Steve Fry suspects a protozoal organism, FL 1953. Other researchers, Joe Boroscano, suspects the XMRV virus. We don't know for sure, but we know for sure that the exposure to the electromagnetic fields that we are undergoing right now is insane, and it's driving the growth of the bugs. There's several Russian research papers on that shows that.
Well, thank you for that explanation. And it sounds like from your perspective that one of the most important things you can do, and it makes sense, and clearly the world is coming, the scientific community through the new publications and research is validating the position that we've held for many years, decades, that this exposure to these electromagnetic fields are particularly harmful, and they're causing, serious problems down the road, many of which we're not seeing. I mean, you're certainly witnessing them now with this individuals who are struggling with the Lyme disease process, but there are millions, tens of millions, maybe even more, who are going to suffer similarly that many smokers do now to the chronic exposure to smoke and come down with cancers down the road that are 10, 20, 30 years later. So I thank you for that perspective, and I'm wondering if you could put it into a sort of a priority as to how you base your treatment. Obviously, nutrition is going to be an important component of it too, but do you find from your results of the patients you're treating that the paying more attention to the electromagnetic even supersedes the importance of paying attention to the avoidance of optimizing the diet and eliminating sugars and those types of aspects?
Yeah, let me so outline our treatment approach. So the first thing that we do with the patient when we entering now the treatment decisions is that we look at the external factors that act upon the body of the patient 24 hours a day, 24/7. So we try to clean up their home, their sleeping location, their work location. And the very first thing we look at is mold. And there's a very important new book out by Richie Shoemaker, his new book on mold. It's called Surviving Mold. It's a website with the same name. And we do, with every patient, we do mold testing at home. And we do what's called the ERMI score, ERMI. The ERMI score is a semi-quantitative assessment of how much mold is in your home. And there is a sort of experiential value. The number shouldn't be over 2. Most of our patients are around 15, 19, 20. And then the first question that needs to be solved, mold is a huge contributor to the same symptoms that we normally associate with Lyme disease. And so we try to clean up the home, and the American homes are notoriously catastrophic for mold. The ventilation and the homes are basically big cardboard boxes with plastic wrapped around it. If you really look at the structure, it's like a mold growing fermentation chamber. And so we try to get the mold people in there to mitigate whatever's possible, cleaning up the air ducts, aerating the home for an hour every day, vacuuming, if there's any moist walls,
Yeah, if I can interject here, because I've had a problem with mold in our own home, my own home, and researched this pretty carefully, and the key issue is that moisture. I mean, so many people have hidden leaks in their roof or their plumbing or their foundation crack in their basement. I mean, it's because you cannot have a mold-free home if you have a moisture intrusion into the home. It just is impossible.
And then we have the other thing is the floor space. Very often we find that the ventilation system in a house sucks in the air from a crawl space that is completely infested with mold and blows the mold into the house. So I think the framework of this interview goes too far to go into all the details. But if a patient lives in a moldy home, we do not have a chance in succeeding with the Lyme treatment. That's the basics, and so I recommend reading Richie's books. Richie is in our inside circles the god of the of the mold mitigation and mold diagnostics, and I think it's a must to become cognizant of that. So that's the first.
What's Richie's full name, and how do people find those books?
Richie Shoemaker, and the website is simply survivingmold.com. So it's a very important resource. Now, I don't agree with all the conclusions and all the therapeutic steps that Richie Shoemaker does, but in terms of the foundational knowledge and the science that he offers, it's fantastic. And there's a couple of lab parameters that we use that he is recommending. One is called TGF beta 1, transforming growth factor beta 1. It is an inflammatory indicator. It tends to be high when people are exposed to mold. The other one is called C4A. It's one of the complements. Unfortunately, the test needs to be done in one particular lab in the U.S. It's called the National Jewish Hospital in Denver. If C4A is up, that's also an indicator for mold-related inflammation. So we do a few other things, but those two are the two big ones that we do with the very first visit to see is there any indicators here for mold. And then we do a visual test. It's called the visual contrast score. I know you're aware of that because you've been to those workshops that Richie Shoemaker has introduced to us. It's a test that measures the ability to see contrast, black and white contrast. It's a simple apparatus that we have in the office that anybody can learn in 10 minutes. And it gives you a score, and if it's below a certain level, you know the patient has an ongoing mold exposure. Unfortunately, there is no clear simple mold testing where you do a blood test and kind of say, oh yeah, you're mold exposed. There's over 600 pathogenic molds, and it could be astronomical testing for it. And so we reduced it to this minimum of tests that gives us good guidance, and then we use muscle testing to confirm, yes, there is mold. And then we need to treat the mold in the patient, and we need to treat it in the home. Treating in the home is most important. And here comes the most important other thing, and that's the electrosmog. We know that the mold in the home gets by a factor of hundreds of times more virulent if it is exposed to microwave from incoming cell phone radiation, from wireless internet, from baby monitors, from alarm systems in the house, and so and from the cordless phone. The cordless phone broadcasts 24 hours a day, a very devastating pulsed frequency into the house. And so we know that the electrosmog grows mold in the house faster and more viciously than it would otherwise. So the next step that we do, we measure the microwave in the homes. We have an instrument that we give to patients. They have to send it back. It sometimes goes wrong. That instead of keeping it for one day, they keep it for a month. And it's a $1,000 instrument from Gigahertz Solutions. That's right now the accepted gold standard for measuring incoming microwave in the house. And there's a certain value scale. I'm not going to go into that here, but we measure every home of any chronically ill patient. We want to know how high is the score. If it's beyond a certain level, the patient has to what we call mitigate. That means there's two ways of shielding the home from the incoming microwave. One, the best one is to put a special graphite paint called Y Shield, Y, the letter Y, and then Shield on the outside of the house, and to use curtains in the house that with silver-coated cloth. That's what we did in the office, and it's fantastic. It's like coming home, going to work, because the office is shielded from the incoming microwave, and everybody breathes deeper and feels at home, when you're in an environment like this.
Yeah, the downside of that for those who are going to do this is that you won't be able to get cell phone calls.
Exactly, exactly. So, sometimes compromises work well. So people just shield the bedroom and, leave the other rooms contaminated, but then be able to receive cell phone calls, or, get a corded phone in addition and tell all your friends, what your phone number is, and that works very well. But, that's step number one. Step number two, no cordless phones in the house. So the phones that are incoming phone lines need to be either corded, or there is Siemens and Motorola both make phones that only broadcast the microwave, the connecting frequency, when there's a phone call coming in. All the other phones, the ones that most of the listeners will have at home, are broadcasting a signal 24 hours a day.
Well, if I can give a refinement on that, because this is from Vicki Warren, who we both respect as an important former director of the Biobiology Group in the United States, is that there's the base station is really the offender there, and it's not so much the receiver. So if you can put the base station like more than 3 or 4 rooms from where you're sleeping, or spend most of the time of the day, then the radiation goes out over so much, and it's not an issue. And it really is only an issue when you're talking on the phone, because that's the only time it transmits.
But Joe, I have to remind you that the only person I know that has 3 or 4 rooms to go to is talking to me right now. But, most of us live in small apartments. Sort of.
Yeah.
That's not an.
Yeah, then it becomes a mood issue. Yeah, but the other alternative is and they are difficult, but you can go to eBay or Craigslist and you can find the older generation 900 megahertz phones, and then those only transmit when they're on. But all the others transmit 24/7, just like you said.
Do you have those instructions on your website? Can people find it?
We do. Yeah, but every time, and we have a whole EMF site. It's emf.mercola.com, and she goes into that. But Vicki's, really just brilliant electrical engineer who's committed her life to understanding these processes, and she's talking a lot.
The third thing that we do is that every patient has to turn off all the fuses at night until they're well. They can get a demand switch and do other things later on, but while patients are under my care, they have to mitigate the incoming microwave. They have to get rid of the cordless phones, and they have to switch off the fuses at night. This is preconditioned by me for the Lyme treatment. The mold mitigation and the electrosmog mitigation. And then we roll our sleeves up and treat the patient. So I just want to say this is not like a spiritual idea anymore, or in a nice world we would be doing these things, or maybe we consider those things sometimes. No, every single patient who walks in my door gets these instructions at the beginning, and we follow up with that. And
well, let me emphasize that's a golden pearl. And for those who are listening, I mean, you really need to listen to this because you've spent decades figuring this out, and you've learned from hard trial and error, and people spending thousands or tens of thousands of dollars in unsuccessful treatments, that unless they're doing these 2 things you recommend, the treatment's going to fail. And that's a good strategy for everyone listening, whether or not you have Lyme disease, because there is no way mold exposure is going to make you healthy, and the same thing for EMF. They're both toxins that should be limited. So it's wise for everyone, but if you have Lyme, don't even think about getting treated successfully unless you're addressing these issues.
Yeah, and we see there's 2 groups of patients. The ones that we get well, those tend to be the ones that have done those 2 things, and the ones that struggle, and it's a slow uphill struggle, if at all, if they don't do those 2 things. So I just want to put that at the beginning before we launch into the actual treatment that everybody expects, okay, what are the things that you do to treat the patient? Well, those are the first 2 things that I do. Fairly early on in the treatment, we get the trauma history of the patient and the family history, and we look at if there's any major trauma, any major losses, the death of a loved one, trauma in the family. The father was in Vietnam and lost a leg. Major traumata, we want to know about that. And I do my PK work on the patient early on if we find that. If the issues are more subtle, I wait until the patient has made a degree of recovery when they're more able to sustain a deep look inside, when they're able to introspect and look at their stuff. Usually
And,
it's
and let me
later.
let me just interject here for those who don't know your work. That PK is psychokinesiology, and that's a more advanced form of similar to EFT, but far more advanced, and incorporates some of your decades of understanding and teaching. So.
Yeah, and we use all the principles of EFT, which I learned largely from you. And so the psychological treatment, really, I want to say it very clearly, if there's a major trauma in the patient's history, you have to deal with that early on. If you have to refer somebody to a trauma therapist, fine. So we do that in the office. I love doing that work. Not everybody does, and don't take it with a sense of shame. But if there is a major trauma, your treatments are not going to work that you do later. And so we do that early on in the treatment. But the family conflicts and love issues, relationship issues, we park that, because most of the time the psychological well-being of the patient is totally dependent on the absence of the microbes in the brain. If you have microbes in the brain, you cannot do any higher psychological work, even though the presentation of the patient may look psychological, but the underlying cause of that often is the inflammation in the brain and the toxicity caused by the illness. So let's launch from here. So this is the other three steps: the mold, the electrosmog, the psychology. And from here on, I launch pretty well into the Lyme treatment that we are exploring and have been very successful with. So just a little bit on the history of that. So when I started out with Lyme in the early 90s, we used antibiotics. I was largely surprised initially how well antibiotics work in chronically ill patients, that we really see some progress. But then also saw that we fairly rapidly reached a plateau with the patients that we treated that way, where it was really, really hard to move on from there. And I have a large background, as you know, in alternative medical treatments. I was trained a classical homeopath, and then did a lot of herbal training, and then learned the whole integrative medical stuff and hormone replacement therapy and all those things that many of the listeners also have learned. And I fairly quickly decided I will try to figure out a non-antibiotic way of treating this illness. So the first big breakthrough in my own personal life, what healed me from Lyme disease, was bee venom therapy. Bee venom is the poison the bee uses to scare away attacking invaders. And all of you have had a bee sting at one point or another. Bee venom contains a peptide called melittin, which has been found to be an extremely effective antibiotic for Lyme disease, but recently also has been found to be a very effective antiviral for many of these hidden stealthy viruses that come with it. So my first line of treatment in this is from the early 90s was bee venom therapy, and we were very successful with that, but it's no longer the first line of treatment that we use. We explored a large variety of herbs, and I'll just give you the conclusion we're doing now. We treat Lyme disease with what I call the Klinghardt antimicrobial cocktail, and we have a one-page protocol that gives you the details of my cocktail. Wormwood has been used for treatment of infections since over 1,000 years. It's documented, and one extract of wormwood called artemisinin has been found to be extremely effective for malaria. So we put in most effective herbs for Lyme disease, put it in an herbal tincture. It's called quintessence, like 5, and the quintessence goes into the cocktail. And so that part we make as a liposome with a blender, and then we use this ultrasonic unit, and then we put it back in the blender, and then we adding in all other vitamins and things that can possibly be taken orally. So we open capsules and put everything else in there that the patient needs to take for the day. And then at the end, we're adding some apple. I like to put an apple in there because of the apple pectin has wonderful healing properties and binding toxins in the gut, and also giving the fiber to the gut to give this whole cocktail a structure that is slowly delivered. We don't want it all to be absorbed within a few minutes. We want to slowly deliver it. And so We go through a number of steps in adding some other ingredients to it that are more particular to that particular patient. But the core piece is artemisinin, the quintessence, the 5 herbs, and the vitamin C, together with the phospholipids. And that has been just a dynamite, incredible thing. You know, most of the patients that I see are people that have been often 3, 4, 5 years on continuous antibiotics to keep them alive, and they had probably improved on it at some point, but they're still in a devastatingly low level. And those are the people that typically we get well or a lot better with our cocktail, with the sequence of treatment. And the new thing is basically that, yes, we can make anything liposomal. You can take any herb that's effective. I said in the beginning, usually in the beginning of the treatment, many of our patients test positive for parasites. And we tried all the antiparasitic drugs that are out there. There's one particular nasty parasite I want to mention that's called the lungworm in dogs. It's called the lungworm, as it made the transition into humans. It's one of the roundworms. It's called Varus strongylus klaphowi. Larry Klaphow is the biologist who discovered that one. And it's in over 80% of the chronic fatigue patients it's present. And when you successfully eliminate the parasite, the fatigue is gone. There's a direct relationship. I've been working with that now for 4 years, and I'm absolutely convinced that this parasite is present in most people with chronic Lyme disease. It should be treated first. And the way we're treating it is twofold. One, we create a liposomal worm cocktail. We use an herb that, unfortunately, last time I even mentioned it only at one of my courses, and the entire stock in the US is bought up and no longer available because the sources have immediately dried up because there isn't enough production. So I'm not going to mention it to you, Joe. But there is a medical drug that comes close to it. It's a cocktail of ivermectin is the key ingredient for the lungworm, and we use a high dose of 12 milligrams 2 to 4 times a day, and we put that in the cocktail and then make it liposomal, and with that we have a huge effect on the lungworm. And in addition to that, we let patients inhale SSKI, that's a potassium iodide, because it kills the parasite on the surface. And that is has become a hugely important first step to eliminate the lungworm from the patients. And with that, everything changes. People feel better, they have more energy, the brain gets clear, long before we even get to treating the Lyme disease. You know, so we do the parasite thing first, and then we do the cocktail for the Lyme spirochetes and Babesia and Bartonella.
That's interesting. I just read an article today or yesterday that noticed an observation that in Africa, when they put patients, I think it was some type of parasitic infection, I think called river blindness in Africa, and they treated them once or twice a year. I think once a year, and they're trying it for twice. But they noticed that the communities where the individuals were treated, that they radically reduced the incidence of malaria.
Absolutely.
Yeah.
It's the same here. You know, the relationship between parasites and Babesia is the same as the parasites in Africa and malaria. People that have parasites don't have defenses against malaria, get malaria. You eliminate the parasites, and the malaria has no chance of finding fertile ground in the patient. And so it's been, I can tell you, Joe, how effective the strategy has been. Now on my website, you find my more sophisticated medical parasite protocol, the different drugs that we're using for it. And just kind of know there will be, once we secure like the one herb that works so fantastic, once we secure like a pipeline that comes from the Himalayas, and there's a limited growth, but once it's there, it's going to be much easier to treat a lot of people in a natural way, which is my goal with this. It has to be natural. And so the last step that we do is the treatment of the viruses. You know, so we start with the parasites, we address that, we try to get positive lab tests. It's very difficult in the US. Maybe I say something to that also. Why doesn't everybody know that they have parasites? Well, I ran a parasite lab in India for 2 years. I worked with one of the top parasitologists in India together, and I was running the lab. And it is a ground rule in parasitology. If you want to find a parasite, you have 20 minutes from the moment the patient has a bowel movement to finding it in the stool. After 20 minutes, most parasites use a process called autolysis. They simply release an enzyme that completely makes them disappear in the poop. And what do we do in the US? Right? We collected the poop, it sits around on a shelf, then it gets sent by mail to the lab. And 3 days later, a lab technician looks at it. It's a joke. And whatever we're still finding is a miracle. But we don't have parasitology in the US. We have no available, reliable test. I know Metametrics is trying to do a DNA-based test that has a little bit of a higher detection rate, but the false negatives are so bad. The way we diagnose parasites, we put people on a treatment and then look visually in the poop, and that's my diagnostic test. And most of the time, we can document the parasites. Now, last word to that: many of the parasites are now microscopic. They're embedded in the same biofilm that the Lyme spirochetes are embedded in, and they're harder and harder to detect with the eye. And they're constantly mutating the outer surface proteins. They're very, very hard to detect in any lab test. And so we pretty much very often have to assume the patient has parasites, treat them, and then judge by the clinical success that that's what it was, and it's huge. So we start with the parasites, then we launch into the Lyme cocktail, as I call it, that liposomal mix of things. And then the last thing that we do is addressing the viruses. It's important to know, there's some good evidence that artemisinin and liposomal form is very effective against XMRV, the new suspected cause for chronic fatigue. Many of the herbs that we're using are antiviral, and we have a viral tincture that BioPure makes for me. It's called Virescence, where we put the key herbs together. There's a Native American herb in there that's very, very effective for most of the fatiguing viruses that we're dealing with. But the basic principle with viruses is you cannot treat a virus with viral killing agents. You have to treat viruses indirectly. And this is now where the diet comes in. And this is where sometimes the methyl B12 injections come in. And this is where other strategies come in. We have to treat insulin resistance, which we use Jonathan Wright's new protocol for insulin resistance, which is fantastic. He dug up the literature on it. We give people 1 gram of niacinamide 3 times a day, and berberine, it's basically Oregon grapewood. We have that in a tincture. It's called Virescence. It's 2 dropperfuls 3 times a day. That's over 4 months, 100% successful in treating insulin resistance. Just one word to that. Joe Boroscano published it a few years ago that virtually the main known cause for insulin resistance that we find has nothing to do with the things that Mercola found. Is Lyme disease. Lyme disease induces insulin resistance. How do we know that? When we treat Lyme disease successfully, the insulin resistance is gone. And now Jonathan Wright came up with this beautiful, simple protocol that he dug up in the literature. And so far it's been 100% successful. And what I want to say here pretty much towards the end of the interview is that if you have a Lyme disease patient and you treat the insulin resistance, everything else is going to go easier. And
so would that mean the clinical conditions typically associated with insulin resistance, which would be obesity, diabetes, high cholesterol, hypertension?
The amazing thing is in the Lyme group, there's a subgroup that has severe insulin resistance, with high insulin resistance in the morning and high insulin levels in the morning and all the things. And they're skinny, they're vegetarians, they try to exercise as much as they can. They do all the right things, and they still have the insulin resistance. And so they have a completely different expression of the things we normally associate with it. So insulin resistance, I know it's a whole other topic or so, but it's a huge part of the treatment of Lyme disease is handling insulin resistance. With that, usually all the arthritic symptoms go away, and the fatigue greatly improves, and the sleep improves. And so things that we normally don't associate with insulin resistance improve dramatically. Jonathan Wright showed us clear evidence in the literature that osteoarthritis is an outcome of insulin resistance, which I didn't know, And so thanks to Jonathan, this has been a beautiful, beautiful treatment addition. And I found Italian literature. I mentioned that in one of my talks with you years ago, that niacin has been found to be very, very effective antibiotic against Lyme disease. So there is a link. And niacinamide has the same antimicrobial activity as niacin has. So,
but they're different, niacin and niacinamide, because the niacin will give you the flush, niacinamide won't.
Yeah, but the antimicrobial effect has been shown to be identical whether you use niacin or niacinamide. Yeah, nobody knows really how that works, but they did culture experiments, and both have the same. Maybe I say something to this. There was a cluster of outbreaks of beriberi disease in Italy, which was treated with vitamin B3, niacin, and the illness went away. And so it was concluded that it was a niacin deficiency, because what goes away with niacin must be a niacin deficiency. Years later, researchers came in and said, well, that's, you can't really do science like this. Let's look what these people really have in these clusters in Italy that have the vitamin B3 deficiency symptoms. And they did tissue biopsies, and found all of them were infected with spirochetes. And so they realized that the high-dose niacin, was a gram 3 times a day, was a very, very effective treatment for Lyme disease. And then we looked up in the literature and found that niacinamide has the same antimicrobial activity. And so treating insulin resistance is interesting with Jonathan Wright's new cocktail, also covers the Lyme spirochetes to a large degree. So it's a beautiful thing to add in. There's no side effects from it, and it's been a wonderful, additional little.
How long have you been using it?
I taught a seminar, a deep look beyond Lyme disease, which I recommend. By the way, everybody gets the DVDs or the course handout, because all my tricks are in there, and that's the first time I introduced it. That was maybe 4 months ago.
Okay, so it's relatively new.
Well,
and this is another classic example.
I used it about for a year, but it took about 8 months for me to really speak about it with authority.
Sure.
So,
yeah. So you're always on the bleeding edge, and that's why. I mean, it's great to have this information. But if we come again next year and talk about Lyme disease, you're going to have 3 or 4 new updates that are really pretty groundbreaking, and let me just state to that fact that it's not making it more complex. I mean, the beauty and the elegance of your approach is that it's all about simplification using natural methods. So it becomes simpler and easier, not more complex and harder, which is the traditional path that most physicians go towards.
There's another side to it, so that we have enough. I've been at this now for 36 years, but the more narrow Lyme treatment in the last couple of years, it is clear that with this approach, we're also addressing Parkinson and MS and chronic fatigue and illnesses that are not on the surface associated with Lyme disease. We treat a lot of children. Half my practice are now autistic children, and we put them through the same treatments and with fantastic results, and they get their life back. And so it just became my window into medicine and into life to approach medicine from that way. And believe me, once people get better, they get put on the exercise program and they get put on your website to learn how to properly exercise and how the different dietary things that you've so wonderfully explored. So that's sort of all over the world. So I have a following in Germany, in England, Switzerland, or so, and I direct them to the website. Once they're through the initial eye of the needle type of narrow treatment of the infections, we release them, basically into your hands to take them from there into the greater levels of health. And that has been a wonderful, rewarding journey.
Well, it is, and it's interesting that because there's a similar analogy in traditional medicine where they'll just take diabetes, for example, and they've got these oral hypoglycemics, these agents designed to lower blood sugar, which is only a symptom, but no way, shape, or form the cause of the disease. And because you're not addressing the cause, they get other diseases. They get heart disease, they get cancer, which because they never looked at the underlying treatment. So similarly with you, you're not treating symptoms, and unlike other physicians who are essentially treating symptoms by giving them antibiotics. Uh, and it does give them partial improvement, but it's not addressing the cause. So when you address the cause, you not only treat Lyme, but you treat all these other diseases that you mentioned.
Maybe one last of the last words. I do not want to poo-poo the antibiotic approach. There have been times, with our patient where we used antibiotics, but maybe for 4 or 6 weeks, not for 6 years. And I do, and I do feel that ILADS, the group that promotes the very vigorous treatment of Lyme disease, ILADS, ILADS, International Lyme and Associated Disease Society, is by far the most responsible and best group, where really I've learned a lot, and I do recommend people go on that website, ilads.org, and learn everything about Lyme disease that's known, and consider, depending on where you live in the U.S., consider the treatment that's offered you through a Lyme literate physician. Most of them have been through the training at ILADS, and I do recommend that. But there is a level beyond that, which I'm hoping I'm introducing here. If you just do antibiotics, okay, you just do antibiotics. But if you think more holistically, you do the things that I recommend, and then you no longer need to resort to antibiotics because you cover the system on so many other fronts. And with that, we're not only treating Lyme disease, but we're preventing cancer, we're preventing diabetes, we're preventing Alzheimer's disease, we're preventing pretty much all the other things that we didn't know were associated with Lyme. So by treating the mold, by getting electrosmog under control, by treating the infections, by treating insulin resistance, we're preparing the patient for a much happier and healthier, longer life. And more productive life, which is of course what I'm hoping for, that everyone who's been ill becomes an advocate for our environment and for sane living, which we need desperately right now.
Well, it's also, I mean, just to benefit from your experience, it seems very foolish, even if you're embracing the antibiotic concept, which many people listening to this will, to ignore the years of experience you've had, that unless you address the mold and the electrosmog issue, right, you're just not going to get better. Whether it's your therapy, anyone's therapy, you've got to address those first. Right. So, you're just wasting your time, effort, energy, and resources unless you follow that advice. And it's going to be good, even if what you say is wrong, which I don't believe is the case, but even if it was, it's still going to help you in other ways. So there's no negative to it.
And let me say one thing here. I had a fantastic teacher in classical homeopathy while I was going through medical school. And, at the end of one session, he introduced like the 50th remedy with all the details. And I said, listen, like, Dr. Köhler, all these remedies look the same to me. Like, they all have the same kind of picture, little different shades here and there, but they're all the same. And he looked at me and he said, if you give the patient the one wrong homeopathic after another, the input to the immune system, the challenge to the system will be such that the patient gets well with all the wrong remedies. And I took that pretty much into my life as a physician, that even if the things that I'm doing are in the moment maybe the wrong thing for the patient, it still will lead him to higher ground on the long run. And it has been absolutely true. Of course, we're not God. We're not trying to be God. We're doing the best we can. And very often we do things that may be unnecessary for the patient, or maybe the wrong timing for this particular treatment, and the patient still get well, because the system is very forgiving.
Yeah, and I think the reason it is so forgiving is because you're focusing almost exclusively on natural therapies. And if you're using a conventional approach, and the antibiotics are certainly part of them, especially, Cipro and these fluoroquinolones that are toxic and can kill people. We have over 100,000 people every year That's a large number. 100,000 people every who die from appropriately used prescription drugs, not abused, not overdosed, just given at the right doses, they die from them. So, that's the risk when you go with that model. When you go with your model, yeah, it may not work, but at least you're not going to die, and most likely you're going to be catalyzed down the path of healing.
There was a time, I mean, I like to say that still to antidote that a tiny bit. There was a time when I thought I would kill everybody by putting them on long-term antibiotics, and I was amazed if antibiotics are used correctly, like ILADS is teaching, how actually relatively safe it is. But it's not aesthetic, it's not elegant, it's not in keeping with the earth, it's not fulfilling the yearning of the earth, that we work with the earth together with the things that are offered to us by the earth. And I think my approach certainly comes from that, wanting to be part of the earth and not like a superimposed parasite that lives off the earth but doesn't give anything back. So we're looking at more like how can we live in harmony with the earth, where the earth benefits from us and we benefit from the earth. And the approach that I lay out in the recorded meeting, A Look Beyond Lyme, certainly is in keeping with that.
Yeah, well, my major objection to using the antibiotics is my new deep-found appreciation for the gut ecology, and I've certainly known about that for a long time, but it's just become even more importantly obvious to me that once you disrupt that flora, you're really exposing yourself for a whole risk of potential pathology. And the newest appreciation is this risk exposure to autism. And Dr. Campbell McBride has done some of the work. She's a Russian neurologist who has an autistic child, and she found in her experience that it was this disturbed gut flora that, in combination with other predisposing factors like vaccines, that really contributed to it. So, if you've got these people who are on the antibiotics for months, even though they're on a safe protocol, there's no question you're disrupting their gut flora. So you have to address that in some way. And I suspect that's part of their protocol. I haven't looked at it, but it's still a problem. And you've just when.
Absolutely, and maybe one thing to that. I know that you have a new probiotic that I'm excited about.
Yes,
but it's amazing when you think we have 400 different species of microbes in the gut, and the best probiotic that we can buy, has maybe 2 of them in it.
Yeah.
How about the other 398? We in Germany we have a couple of products that have some healthy E. coli in it. Okay, that's 3 species. We got Acidophilus, we got Bifidus. We got a couple of healthy yeasts, and we got coli. That we got maybe 5 species of the 400 that we can actually currently give to the patient with your product. Maybe there's another 5.
Right.
So, but I think one thing that we're really struggling with in our medicine is that the probiotic science, sort of in a way, I'm sure you agree with me, is at the very beginning. We can do the best there is right now.
Well, and probiotics are a supplement. Ideally, you use a fermented food, that has been used for ages in many cultures, and there's a whole variety of different ones. And that's really the first approach. And then not putting weed killers into your system like the sugars, which kill them, or antibiotics, or these other factors, birth control pills that really disrupt that. So, and I think the part of the reason why even if you go to supplements as they tend to work, is that when you combine it with the dietary approaches, you limit the growth of these bad populations so that eventually they don't suppress, it's sort of a competitive inhibition, the process that's going on there. So the other ones that, even though they haven't been disrupted completely, they give an opportunity to grow. So, if you remove most of the weeds, then the good guys can grow.
Yeah. And as you know, I was raised on sauerkraut.
That's phenomenal. That is like one of the best fermented foods. I'm actually culturing some right now in my garage.
You got to watch out. You may start dreaming in German.
No, it is a very powerful food, and it's relatively inexpensive to make. I mean, it self-cultures,
I got to come visit you again, Joe. I want to look that up. Because I have no idea how to make sauerkraut, but I grew up on it. It was a poor people's food. That's what poor people fed their children if they didn't have anything else. You could always get sauerkraut.
One of the things I've learned that Dr. McBride teaches is that is to use some of the sauerkraut or the juice from the sauerkraut right before you eat. it's a very powerful way to enhance gastric acid secretion. So and it's a massive problem for most people is stomach distress, and that's why they're taking so many antacids and anti-ulcer drugs. So powerful way to do it. It's simple, and it just rebalances that gut flora, but it also improves the whole function of the gut. So
I agree. I agree with you. I heard you say this, but I think it's true. We pretty much know everything that's going on inside the cell. We have no idea what's going on inside the gut.
Yeah. It is so key, so key. So that is just phenomenal. I'm particularly intrigued with this new liposomal system that you've got going, and the implications. My mind is spinning because it's massively the potential is so massive for what it can do in so many other different areas. I mean, we know that one of the hottest things from nutritional science right now is this liposomal C, and
you can make it in a blender.
Yeah.
For a fraction of the price it costs you elsewhere.
Yeah, and the liposomal C is so useful even at the higher price because it's still better than the intravenous vitamin C that most of the alternative medicine physicians have used. We both use it in large quantities, and that takes a long time, and you've got to go to the trouble and hassle of getting an injection, go to the physician's office, So and it's not comfortable.
I know.
But the liposomal can be every bit as effective or potentially even more effective.
There is a liposomal explosion going on as we're speaking, but really like that is so easy to make. That was a big breakthrough for us that we can take anything that shows up in our field that works for Lyme disease, we can make it work 20 times better by making it liposomal in the blender next to the kitchen sink.
And how did you develop that? Was that something you learned from someone else, or did you just figure it out by trial and error or muscle testing?
I figured that one out by listening to the vitamin reps at the different conferences, and putting different sentences together from different researchers, how they're doing it, and I realized there's no space science. there's no space science. It needs a blender, and it needs an ultrasound unit to vibrate it at the sound frequencies that make smaller and smaller bubbles. And, that it's not a $500,000 piece of equipment that's needed for that. And so I don't want to put the liposomal products down that are done, somewhere in a pharmaceutical place or so. They may be by a fraction more effective than the self-made ones, but the cost-benefit ratio is so dramatic, and we have, BioPure has a liposomal vitamin C that's excellent, but I like to make my own in the kitchen sink. I like to take a teaspoon of vitamin C and put it with the liposomes and have a huge effect on it. Like flus are non-existent since we know this. You take a teaspoon of vitamin C and a tablespoon of the LipoHealth powder, put it in the blender, put it through the process. 2 hours later, the flu is history. I mean,
well, what type of vitamin C are you using? I mean, specific, because there's a whole argument. You can use ascorbic acid or the calcium ascorbates or the calcium or the salts of the vitamin C that are any more beneficial than others.
I use a product that has a lot of the natural cofactors in it. It's I don't want to actually say the name because it's a commercial available product that's used for people suffering from allergies, and it has some quercetin in it and some of the typical flavonoids and other things from acerola and from some of the natural. I do strongly feel that the cofactors of vitamin C are just as important as the vitamin C. However, this is for the long run. For the acute one, just straight ascorbic acid works. It's absolutely work. For the acute flu, there's nothing like it. Just a teaspoon of vitamin C, you get an effect of 10 to 20 times more. So 5 grams of vitamin C, which you typically have on a teaspoon, turn to 50 to 100 grams of vitamin C in terms of the effect. And that's the effect of a really strong IV or more.
Yeah, because an IV is typically 25 grams, at least in one ampule. I mean, you can certainly put more, but if you're taking 50 or 100 grams, it's going to take you 4 hours to run that IV.
It takes forever.
Yeah, and what was the other component? Oh, the other element that just I'm sure you can affirm is that when you do the liposome, one of the side effects of oral vitamin C is diarrhea once you get to a threshold dose. And when you have a liposomal function, because of the absorption, it bypasses that, goes right into a bloodstream, and you don't have any diarrhea.
It's long absorbed before it can cause diarrhea.
Yeah. So
Yeah,
if it's causing diarrhea, then you don't have a liposome because it's not working.
exactly. That's how we can test it.
Yeah.
Yeah.
So it's great. So you have any other, I guess, from a person who is a typical candidate you're seeing or people you've seen that are applying these strategies in a diligent fashion, where they're really taking to heart what you're saying and really being good about applying the principles. What type of percentage of people are you seeing improved? And you see probably the worst of the worst.
Well, typically, when we start somebody on a protocol, we expect the first 2 months to be a little bit rough. They go through a different die-off of parasites and of spirochetes and other things. But we expect already after 4 months to be the patient on higher ground. Sometimes it takes usually I see a patient only once every 4 months. So on the second visit, I expect them to be on higher ground. And between the second visit and the third visit, 4 months later, to reach much higher ground. Now, of course, I'm specializing in the failures of everybody else. So I have my friends in the Lyme field send me their difficult patients. And so with difficult patients are also difficult for me. I'm not going to mince words with that. But the difficulty usually arises because the patients are financially at the bottom and they don't have any help anymore. Their husband has long left them. And when I send them back and say they need to mitigate the mold, they don't have the means, either psychologically, mentally, the strength, the will, to translate that into action. And the typically chronic devastated Lyme case that we see is often not able to mitigate the mold and mitigate the electrosmog. And so my preconditions are not met. And so with these people, we struggle. At first, we have to get them biochemically better in spite of the continuing offending influences at home. We have to get them biochemically better to where their mind functions to a degree, where they develop the will again to put the things in motion that they need to have a healthy home to continue to improve. And so that really is our main obstacle, is the practicality of it. That the changes that people are asked to do in the beginning are massive and absolutely necessary. It's not like me being willful with the patient. Unless you do what I say, I'm not going to see you. But they're absolutely necessary for the patient, for the chronically ill patients. The mitigating the electrosmog is an absolute must. Mitigating the mold is an absolute must. And if the patient doesn't have the support system around them to put that in place, those are the patients we struggle with. There's occasional, of course, patients that do everything right, and we still don't get them well. It's rare, but that's of course life. These are usually my teachers. They are patients that are there to teach me something I don't know yet, and I'm open to that, and I don't take it that personal anymore. My ego has long been gone, has long been destroyed on that, so I don't take those things personal. But I recognize some of my patients as my teachers. The difficult ones that need a unique route that at the end, looking back, probably will have taught me something new. And that's how new things come about.
Sure. And because I've had a personal struggle with mold in my own home, I've done some research and interviewed a number of experts in this field, including Dr. Doris Rapp. And some of those articles will be appearing shortly. So there's some resources that we'll have for people, in addition to the Richie Shoemaker one you mentioned earlier, who I'm actually going to contact and see if we can interview him. And what I just wanted to mention is that you're right. There's no question that mitigation process can be quite expensive. I mean, in my own case, we spent like $30,000 to do that, maybe a little more. It doesn't have to be that expensive if the problem isn't that big, but typically it can be. And in many cases, the home has to be demolished because you just can't remediate it. So, and then the person might have to go and rent or do something. But it can be a big issue. So we're going to provide some more practical strategies and hopefully, because everyone really needs to address this, to look at these hidden factors, because this mold can be insidious. And if you catch it in an early stage, just like prevention, it's going to be easier and far less expensive to treat. But if it goes on for a while, it just grows and it just damages and destroys. And then before you know it, you have to rip out half your house.
Mm-hmm. We taught, by the way, a couple of years ago, a seminar creating a healthy home. And we have excellent mold experts in there. And there's also for the listeners here, they may want to review the whole seminar. It's a whole 3-day seminar that's going lecture after lecture on the aspects of toxicity in homes, focusing on the mold and what to do about it, where we have some of the leading experts in there. So it's just a thing where we all need to become cognizant and informed about. And then basically the core problem in America is, okay, we have 400 million people now, and we may only have room for like 50, half a million in terms of healthy homes. There isn't 400 million healthy homes in the U.S. available for 400 million people. There isn't, because most of the homes in the U.S. are built in a way where they've become moldy after a few years, and it's a devastating thing. It's something that brings America down on its knees. In Europe, in Germany, we have red brick buildings. It's a stone that breathes, and for buildings to become moldy is an exception. Here it is a rule, and so it goes back, to the Roosevelt years. Roosevelt wanted to create a building code that every American can have their own home, and that was came from a very noble and good place. However, with the current electrosmog environment, it makes each home a mold growing apparatus, and it's a tragic development that we need to find a solution for, and it isn't out there yet, the simple solution that everybody can afford.
Sure.
Maybe one thing, we use a propolis vaporizer. It's an Italian study that shows that when you vaporize propolis at 82 degrees Celsius, it creates a monoatomic vapor that bonds to mold spores and makes them heavy, and they fall to the ground and can be vacuumed off.
So this is not something that people would swallow or inhale. This is something that was a treatment for the house.
It's a treatment for the house. And there's a website where you can get this stuff. Would be nice if you get it on your website, Joe.
Sure.
Yeah.
But the key thing I just want to emphasize is that unless you identify and remediate against the source of water intrusion into your home, whatever killing mechanism you have, however good it is, ozone or whatever, it's just not going to work in the long term, because you cannot kill all the spores. Nothing is. It's like trying to clean and sterilize a root canal. It's like physically impossible. And there's going to be some residual ones in there, and as soon as the moisture hits it, it's going to start growing, and you'll have a garden in there before you know it.
Yeah, and the mold, like I said, is growing now at a much faster rate than it ever did in the history of the planet because of the electrosmog. So it's a synergistic effect between the two. Yeah.
The catalyst. So I just am really grateful that you are so committed and to always expanding the window of knowledge in this area, because there's really not a lot of people like you, and you're a teacher too. You're a very eloquent communicator, and you've really created a body of knowledge that is available for others to learn. So unlike many people, you're out there regularly teaching, and we'll have a link to the seminars that you have. But in case, for whatever reason, it's impractical for people to attend, you've also record those seminars, and there's DVDs and there's books and lectures that you have. And if anyone is interested in what this discussion has been about, and they want to learn more, because we can go on for 8, 10, 12 hours, and really, because we've only covered touched the surface. And if you think you know, as I said, you come back in a year or two, you're going to have loads more to share. So I mean, that's really the fun of having dialogues with you, because you're always coming up with new information. Let me encourage anyone listening or watching this is to access the resources for further information, because there's really a lot more out there that we have not covered. It's just impossible to do it because there's just so much information. So that's my closing words. Do you have any closing words you'd like to comment on?
No, just for those people out there that are ill, please don't give up. We're so close to finding really good and practical solutions for all these things, and hang in there. I give all my recipes on my website, klinghartacademy.com. Joe, you've been a phenomenal resource for the whole world, really, by now, with the information you give people, and there's so many others out there now that are on the leading edge. And just kind of know, sort of, we can't wait right now for studies to come out. The illnesses are moving faster ahead than the universities and the more conventional science community can follow. And so there's a few of us that try to translate as quick as possible what we see, what we know, what science has learned into practical action, and just, keep your ears perked and keep open. And the physicians that are out there, we're in a blessed country in that way here in the U.S. I live here by choice. You live here probably by necessity, but I live here by choice. So it's a fantastic country, and the level of communication, just Joe and you and I, that wouldn't happen in Germany or somewhere else. We would kind of be mortal enemies, talking bad about each other because we're in the same business, And here in the U.S., we have a synergy of practitioners and healers and evolved beings and scientists that work closely with each other. And I do think we're going to find the solutions quicker than the problems arise. And thanks to the internet and to the communication media, I think there's hope for all of us.
Yes, let's hope so.